Well, welcome everyone, and thank you for joining us today. My name's Bill Manning, and I'm Executive Director of ASPI. Quick footnote, I have been on active surveillance since 2009, and I'm still a member of my local support group that got me started on this journey. Our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment, but a management plan. I would like to remind everyone that we are not anti-treatment, but anti-unnecessary treatment. ASPI supports the concept of the proactive patient who is interested in reading materials, watching videos as part of their research, participating in support groups and webinars, and attends, if possible, relevant conferences, and most importantly, establishes decision-sharing relationships with their doctors. We are not here to dispense with any medical advice. Nothing said during these meetings by our speakers, ASPI, or the audience should take the place of consultations with your medical professionals. Now, a quick couple of housekeeping measures. We are going to hold all questions until after the speaker's presentation. You can submit questions in the chat box, which we will try to address. Please keep your questions limited in scope. The doctor does not have time to review your case history. And at that time, you can also click the raise hand button from the bottom of the Zoom window toolbar. And if there's time, we'll try to call on you. And please keep yourself muted during the meeting. The speaker presenting today is generously donating his time, so we want to be respectful of that. You also do not need to feverishly take notes during the talk, as this meeting is being recorded and will be available on our website in approximately 1 week. You will get an email notifying you when it's ready. Also, if you subscribe to our YouTube channel, you'll automatically be notified when a new video is posted. So, without further ado, we'll have a few quick words from Mark Lichty, our chairman, who will then turn the meeting over to Howard Walensky, the organizer of this meeting, to introduce our guest. So relax, enjoy the meeting, and I hope you leave a little bit smarter. So take it away, Mark.
Thank you, Bill. And I want to thank you all for attending today. These webinars are fascinating. I I've been attending them for a few years, and I'm always amazed by the caliber of the people that want to contribute. And Bill mentioned Dr. Punnen, who's speaking here today. None of these doctors seek compensation. They don't even ask for it. They're here today for you because they care about you. They care about the um, level of care you're getting. And so that's the only reason that they are here. And that's why we created this Saturday morning sanctuary for you guys. I wanted to mention too, if you haven't looked at our video shorts on the website, do. They're outstanding. That they allow you to search. These webinars are sometimes a little long. And so the video shorts were edited in-house by us, and they allow you to search a topic quickly. And we know of no other organization that has anything like this. So we need to continue to find ways to do things like this, and we want to thank those of you who, through your qualified charitable distributions or whatever, contributed to us. That they allow us to continue to give you tools that are important to deal with what you're dealing with. I also wanted to mention, Bill said that we are not at all opposed to treatment. You should be aware that 3 of our board members have had treatment, and and 2, what I recently learned after 20 years that my prostate cancer had spread to his lymph node. So that was shocking to me. And I'm in the middle of trying to determine what my next step is. What was recommended was androgen deprivation therapy and radiation. And I'll speak of this a little bit for just a minute here because um, um, a fair percentage of you will be in the situation where I find myself right now, having to make decisions about treatment. And so the recommendation with me was androgen deprivation therapy and radiation. And I've spoken to a number of people about androgen deprivation therapy, and I never heard of anybody that had everybody has had pretty profound side effects. So I'm trying to find a remedy, treatment that will maintain and maximize my quality of life. And that's what ASPI is about, maximizing your quality of life. And that's why you're all here. You want to preserve your quality of life. And we want to do what we can to help you to preserve your quality of life. So this is where I find myself, and I find myself too. I mentioned this earlier, but you weren't all on the call at that moment. I'm in the Pocono Mountains, and I'm having a difficult time finding somebody, an experienced person that'll do a transperineal biopsy, which is the subject of today's webinar. Um, so it's interesting to find myself in this situation where for years I was on peaceful surveillance, almost inactive surveillance, frankly. But now I am on very active surveillance. And anyway, with that I'll end, but I'd like to introduce Howard, who will introduce Dr. Punnen.
Hey, well, Mark, we're there for you, but we're really today here for active surveillance. And I've been on active surveillance. I started on the so-called journey 15 years ago next month. But today we're going to be focusing on an issue that you're facing, Mark, but everybody in this situation faces, and that's transperineal versus transrectal, as well as other issues faced by men on active surveillance. And our speaker today knows a lot about this. And this is Dr. Sanoj Punnen. Sanoj is a board-certified urologist and professor of urologic oncology at the University of Miami Leonard M. Miller School of Medicine. He also serves as associate professor and vice chair of research for the Desai Sethi Urology Institute. He is co-chairman of Genitourinary Site Disease Group at the Sylvester Comprehensive Center. Sanoj, your head should be bowed down with all the hats you're wearing. Now, he has, I think, one of the more perfect pedigrees for active surveillance. After he got his MD at Queen's University in Canada in 2005, he had a residency in urology at the University of Toronto in 2010. And of course, University of Toronto is where much of this started. And he had a fellowship in uro-oncology at the University of California, San Francisco, which is another place where this started. And Johns Hopkins was the third star. Dr. Punnen specializes in treating prostate, bladder, and kidney cancers and is an expert in robotic surgery. He has particular expertise in using MRI and biomarkers for prostate cancer evaluation and in performing MRI-guided and transperineal biopsies of the prostate. So enough introduction. Sanoj, it's your turn.
Great. Thank you, Howard, for the warm introduction. Let me just bring up my slides here. Are you guys seeing them?
Yep.
Okay, great. Um, so I think I had the pleasure of speaking to this group once in the past, and I just remember it being a great experience and having a really good conversation afterwards in the question session. So I'm looking forward to doing the same today. And as Howard mentioned earlier, we can definitely go outside the scope of biopsy and talk about MRI and surveillance and anything else. So we talked a little bit about disclosures and other things. I think it's important that you just some of the other things that I do. So I do a lot of work with biomarkers that includes biomarkers for prostate cancer detection, biomarkers for prostate cancer prognosis. So I speak for some companies, I attend ad boards, but I do a lot of research with each of these, validating the tests and even trying to improve some of them. Some of the funding that I have comes from the NCI, and again is really in the space of imaging, primarily MRI, and biomarkers and how you put them together. And then I have some hats within the Cancer Center, as Howard mentioned. With respect to my pedigree, and this was also discussed a little bit, I grew up in Ontario, right in Burlington. I think I saw Bob Allen with Burlington, Ontario, Canada. So I grew up right in your neighborhood, Bob. And then I did my med school at Queen's, which was 3 hours east of Toronto. And I did my residency in Toronto, worked with Laurie Klotz, who's a big figure in active surveillance. So I did 5 years there. Then I went over to UCSF in San Francisco, and I worked with Matt Cooperberg and Peter Carroll, who you may remember or know some of those names. And while I was there, I also did a master's in clinical research, which is very similar to a master's in public health, but it was a little bit more epidemiology. And it helped me quite a bit in terms of just getting a foundation in research when I came to the University of Miami, and that was in 2013. And I've been there since, but I've played a central role in a lot of the clinical research that takes place there. I've been involved in clinical trials. And some of the clinical trials have been fortunate enough to be funded by the NCI, and they're ones that we write. So we have an ongoing trial that just finished looking at active surveillance and the role of MRI, some of the AI we're doing in that space, and also looking at the role of genomics through the Decipher test, and a few other things actually have come out of that trial. And then we have another one looking at the elevated PSA space and how we can use AI to improve MRI to actually improve biopsy. And I'll show you a little bit of that at the end of this here as well. And then some of the stuff that we're doing. So the agenda really for the day is to talk about biopsy of the prostate and how that's changed over the years. So we'll talk about the history of biopsy. And as today, as we mentioned, there's a much more of a approach to doing a transperineal biopsy of the prostate. Although in the United States, compared to a lot of other places, as was mentioned, you'll still see a number of places that are still just doing transrectal. So I'll talk about the rationale to transperineal, why it started getting more, emergence, and then some of the different approaches to it. And we'll talk about infection, we'll talk about pain, we'll talk about detection, meaning cancer detection, because I think these are the three most important topics around the biopsy, and tell you a little bit about the difference between transrectal. And then we'll look at the data. And then I'll just talk a little bit about, how we do things, and then just something that we're playing with in the space right now that I think will hopefully start to go somewhere, but we're very, very early on in it. Now, I do have some videos that are there that are just showing ultrasound of the prostate, showing local anesthetic, showing some biopsies. So if anyone is queasy at all, I can tell you before a video is kind of coming, and you can look away or something. Or if you don't want me to show it, just let me know and I can pass by. So basically, as we look into the history of prostate biopsy, in the past, before we even had PSA, and this is really in this pre-1980s era, we weren't really discovering a lot of, low risk or low stage cancers. Most men were only detected when, they had pretty advanced symptoms, likely metastasis. And so it's not like we needed a lot of cores from the prostate to make a diagnosis. And so there was really no image guidance around doing a prostate biopsy. The figure to the left here kind of looks at making a cut in the actual perineum underneath the scrotum. where a transperineal biopsy would be, and just making a cut in the skin and then passing a needle until you hit the prostate. And then something similar to the one on the right. Now, the one I think most people did is this one B here, where someone would place a finger in the rectum where they could actually feel the prostate, and over the finger, they would guide, a needle into sampling the prostate. And I had attendings that I had trained with that had done some of these biopsies, and there was several stories of, residents or in that era who had, gotten their fingers with the biopsy pathology coming back showing skin, with that approach. Now, imaging in the form of doing a biopsy really came in with transrectal ultrasound, and that was kind of in the 80s, moving into today, as it still is the main tool that we use to do a prostate biopsy. And so essentially a transrectal ultrasound, exactly as it sounds, is placed into the rectum, and it allows you to visualize the prostate, both in a sagittal dimension, which is kind of from the side, like I show here, and then axial is if you were looking at it like, straight up from the, the view of the tip of the ultrasound, so to speak. And in the past, the beginning part of this, we would kind of identify, the left part of the prostate, the right part of the prostate, and we would take 3 biopsies on each side, which we called a sextant biopsy. And this was now getting into the PSA era, so you would see, a lot of these men that would have rises in their PSAs. We weren't really sure how to follow a rise in the PSA because we didn't use it before. And this whole question of, how much cancer can we find and how hard do we go looking for it, when the PSA era was just very different compared to before having it, where just one core was enough. So this, started this whole thing of, are we missing cancer? And then some groups started talking about doing extended templates, which would involve, 12 cores. So you can see the typical sextant, which is kind of in the middle here, but now you would take another 3 on each side more laterally in the prostate. And what we found was there was more cancer detected in these lateral areas. At some point, then we got into, saturation biopsies of the prostate, which I'll bring up a little bit later on as I talk about transperineal. And that got to a point where we were feeling like multiple, people had elevated PSAs. They were going up for probably other reasons, not a cancer. They've had a few of these, transrectal biopsies that had missed, and now we would take them to the OR, pretty much, poke a hole in every little part of their prostate, looking for almost anything. Now, I think saturation biopsies, which was essentially meaning you go to the OR, you put them to sleep, and you're taking at minimum of 20 cores. Those have gone by the wayside because for the most part, all they found is indolent cancers, because if you're sampling like that, you're just going to oversample a lot of the indolent cancers, which you didn't want to find. And then because of MRI, MRI, allowed us to get another way of looking at the prostate to make sure that we weren't missing cancer instead of having to just go and blindly, whoopee cushion it. So the MRIs, shown here, an MRI is not just a single type of image like you get with, an X-ray. When we talk about MRI of the prostate, we're talking about multi-parametric MRI, which means it has multiple parameters, At the very basic level, it has what we call the T2, which is your anatomic kind of part. So you see the prostate, you can see the bones, you can see the muscle, you see the pelvis in that area. But then it has functional components. Now, this is kind of a heat map, but what it's showing is the uptake of contrast. You can see the arteries, the veins, and it's showing blood flow in the form of contrast being taken up in the prostate. And I think the part of MRI that really brings the power of it, in terms of localizing an area in the prostate, is what we call the restricted diffusion images. And that is really, with the lack of a better physics education, is more of a surrogate of saying how thick is the tissue, because it's looking at how molecules pass through the tissue. And what you see is when it's dark in certain areas, it's just a sign that the tissue is thicker and then more likely being a cancer. So when you put all this together, you see a darker area on this T2 anatomical sequence. You're seeing the contrast sequences showing uptake in the prostate in a certain area. And at the same spot, you're seeing thicker tissue. That can give you a sense that there may be more of a cancer in that area. Now, instead of doing just these random 6 to 12 core biopsies, we would actually target that area. Now, and I think we've seen a lot of studies that have come now into very, very high impact journals that have talked about the game changing of the the field basically because of MRI. You know, if the MRI is negative, the likelihood, now it's not meaning that you don't have cancer, and I think that's an important message I hope everyone takes home, but the likelihood of a bad one is a lot less. And I think the quality of the MRI, the quality of the radiologist, more importantly, is an important thing there. But you'll never get to a point, I believe, where you can say that if my MRI is negative, I don't have cancer. Now, maybe not a lethal one, but you could be missing some of these 3+4 type of cancers. We know that they can get missed on average anywhere from 10 to 20%. The other problem with MRI is there's a lot of variability. I think, you know, even fellowship trained abdominal imaging radiologists, you know, have to have a lot of experience reading MRIs, getting feedback from the biopsies that are done before I think they get a good taste of this and feel comfortable calling something not suspicious. But we see a lot of false positives, a lot of false negatives. I look at my own MRI so that I'm not totally relying on other people. But you know, when you look at, you know, the benefit that you're seeing from these New England articles, and then, yes, we use the MRI, but a lot of that doesn't necessarily translate into the way it's practiced in the real world. And I think you all know that. But in general, yes, it does reduce the number of biopsies we need to do, because if it's negative, we're not doing them often. It does improve the detection of aggressive cancers because you can now know where to put the needle instead of just doing a random. And I guess because you're doing less biopsies, you're detecting less indolent cancer, which is a success because we don't want to find those. And so in the past, if you had something in the very front of the prostate right here, which you may never sample on a typical random biopsy, because you can see, you know, if these were the little cores here, you're sampling the back of the prostate for the most part, you would never actually get to this area. But now that you know it's there, you can actually put a needle right to the area that you need to. So all of this is really just talking about how biopsy has changed over the years, and where we are today is, for the most part, someone would get an MRI first. Not to say that that never happens, because we know there are many places where they're not always doing that. But I think, you know, guidelines and it really is becoming, you know, I think the standard of care to get an MRI first, and then if you're going to do a biopsy, do a targeted one, whichever way you typically do targeted biopsies. Now, the rationale for transperineal biopsies really started, I think, you know, in the early 2000s, when we started to see an increase in the number of post-biopsy related infections. And the reason we saw this is because most of these biopsies, like I mentioned, were transrectal. And so the ultrasound goes into the prostate. And I think I have yeah, you can see right here, the ultrasound goes into the rectum, and the needle passes through the rectum into the prostate. So now you're taking bacteria that normally exists in the rectum, and you're bringing them into the urogenital area where they don't normally exist, and that kind of breeds a risk of infection. And that's what we started to see, is that, you know, we would give antibiotics to prevent that infection. But what we saw is that there was an increase in the emergence of Cipro, which is the typical antibiotic we use, Cipro-resistant E. coli. And with that, we'd see more of these infections, despite the fact that we were giving, you know, antibiotics. So there was a big push to try and, you know, do rectal swabs or other things. And I think the way, you know, that we avoid this today, if we're doing transrectal biopsies, is to give more antibiotics. So if you think about it, you know, we're kind of going in the opposite direction. You know, we got into this trouble by giving antibiotics to begin with, and now if we're giving Cipro in addition to a shot of penicillin, you know, we're just going to eventually breed more and more resistance. So it's not really a good long-term answer to the solution, which is what we're currently kind of doing. And albeit, I mean, as a result, you know, that brings about the rationale for why could we do a different approach. And this is where transperineal really came in. And you can see some of the earlier reports of a systematic review of lots of different studies that were done early on. This is one that looked at about 6,000 patients. And you can see, you know, this was the percentage of this number that was actually readmitted for any real sepsis. So it was much higher than the, you know, 3 to 5% that we were seeing with transrectal ultrasound. You're seeing far lower, you know, than, you know, 0.5% here. And the rationale is in this picture. You can see, as I told you, the needle passes through the rectum and takes the bacteria with it here. And so you really got to, you know, give a lot of antibiotics to prophylax against what's happening. Whereas in this approach, you can kind of see that what happens is, and again, you can see it here too, but this is an ultrasound that's in the rectum because we still use it. And this is showing an example of a grid. And I'll show you that we don't always do that now, but in this picture, it has it, but instead of the needle going through the rectum like you're seeing here, it's actually going through the skin in the perineum. So you're not passing through the rectum. Ultrasound is in there, but nothing goes through. So you're not introducing any of that bacteria now into this. And yeah, you may be having some skin antibiotics there, but this is no different than when you cut the skin during surgery. So if you give just a shot of penicillin at the time when you're doing this, that may often prophylax it. That is essentially one of the main rationales behind doing this TP biopsies, is that it was reducing the risk of these complicated infections. And these aren't just UTIs. I mean, these were real blood and related infections, what we call sepsis, where people get very sick, need to be in the ICU, their blood pressure can drop rapidly. And so when we look at the current approach to transperineal biopsy and what we do now versus how we used to do transperineal in the past, and the past meaning when I was talking about the saturation biopsy, you would basically bring someone into the hospital, usually because you'd have to put them to sleep to do this type of biopsy. You would use almost like a little grid that has little holes in it, and you would pass the needle through each little hole, sampling almost like every 5 millimeters apart. So your goal there was to get multiple, usually randomly placed needle biopsies of the prostate to really be as sure as possible as anything is there. But as I mentioned, it required sedation. This was really multiple cores. Because of all the swelling, there's a risk of urinary retention. And as I told you before, they're all randomly sampling, and most of these guys have had probably biopsies in the past and never found anything. So if you found much, it wasn't a bad cancer. It was usually an indolent one. So we don't do a lot of that. Now the way we do transperineal biopsy is not typically with this grid, although some people still do it, is we put an ultrasound probe into the rectum, and then usually you have 2 little areas in the skin where you kind of anesthetize and pass a needle through, and then you do all the biopsies on one side through one area, and then on the other side through the other. So this is much more tolerable. You're not having, a whoopee cushion in the perineum, so to speak, like you would here. You just have 2 entry points, so you can anesthetize that much better. You're not doing, a saturation. So as a result of the anesthesia, you can do it in the clinic easier compared to this, which you never could do in the clinic. You're taking a similar number of cores as you would to transrectal. So it's not a saturation biopsy now, less risk of urinary retention, and similar risks of similar cancer detection and ultrasound. So the probe is a little bit different. It tends to be longer because you need to see the full breadth of the prostate. And then where you sample is a little bit different. So if you imagine this is looking at the prostate from the side, when you do a transrectal biopsy, the needle goes like this, so to speak, kind of like that, from the bottom of the prostate all the way to the top of the prostate. So when we look at biopsies, you're kind of going to the top of the prostate, what we call the base, which would be up here. And then you're passing the needle from the bottom all the way to the top. Then you come down to the mid gland, and you're passing the needle all the way to the bottom to the top. And then you come to the apex, and then you do the same thing. And that's typically how a transrectal is done. Whereas for a transperineal biopsy, what you're doing, if this is the urethra, is you're kind of coming around the peripheral zone, and the needle is actually passing all the way through the front to the back of the prostate, as you can see here. So this transitional zone around the urethra, where we tend to see more BPH and not as much cancer detection, you're not really sampling as much in there with these transperineals, although you can if you want to, but you're kind of getting a better sampling around this peripheral zone. Now, the thing I think anecdotally here is, if you imagine a person with a lot of BPH, and as men get older, they tend to have more BPH, so this circle gets bigger and it flattens out this gray portion. And then as the needle kind of goes through here to here, and if you imagine the gray circle in the middle being bigger, you're sampling more of the transitional zone and a very little bit of this flattened peripheral zone, as you can imagine right here. So imagine, I don't know if you can see my cursor, but if it's a smaller, darker gray area, the needle is getting much more of this transitional zone. Whereas in the transperineal, you're going from the front to the back, staying in the peripheral zone of the prostate. So the needle, and more of that needle, is in that area, in the area where cancer tends to lie. So I just think anecdotally, the way you're sampling through the prostate allows for better cancer detection, but we'll look at some of the actual data to see, what that is. Oh, I didn't know I had my needles there. So as we move on to the next stage, talking about, the role of antibiotics, because if you had to ask me, what do I think the benefits of the transperineal biopsy are, it's really coming down to antibiotic stewardship and doing a better job for our future generations, so that they don't suffer a lot of the complications of resistant infection. When you look at, this was a meta-analysis that was done looking at the rates of infections after a transperineal biopsy and without antibiotic prophylaxis. You can see there's a couple outliers here where you had about 12, a little over 10, infections out of 100 people. But for the most part, most of the series here were almost like just barely 0 or 1 infection out of 100. So really showing that you can minimize infections without any real antibiotic prophylaxis. And this was a study that was done. It was a non-inferiority randomized trial. And the main endpoint was really looking at infections, not cancer detection, but infections. And what they wanted to look at is if one group got transperineal biopsy with antibiotic prophylaxis, the other group got transperineal biopsy without antibiotic prophylaxis. And what they did is they did it as what they call a non-inferiority, because they're trying to see, is giving no antibiotics inferior in any way to giving antibiotics? And they found that it wasn't. And that's important that they design it a certain way like that, because it requires a much larger number of men to show that something is not inferior. And they did that in the study. And I think that is one of the strongest reasons to do this, is because from an antibiotic stewardship standpoint, like I said, for a transrectal ultrasound to get over this issue of resistant bacteria, we're giving more antibiotics. So we're just going to get more resistant, bacteria. This is just a temporary solution. Whereas in this approach, by doing the biopsy this way, we're not giving antibiotics, we're giving less. We do this in an ambulatory OR, and I'll show you that near the end, and I'll tell you what we do. And I think that is what most groups do. But you're not giving the high Cipro for 3 days, all that type of stuff that you'd have to do with the transrectal. And to me, that's the strongest reason to do these. What about pain? There is a difference in pain, so we should talk about it. And again, this is going to be a video showing how we do local anesthetic in transperineal biopsy. So if anyone is squeamish, it's a good chance to look away. But these are some of the things that that we have on the table. This is the smaller needle just to anesthetize the skin, and I'll show you doing that. And then this is the larger one. So you can see the ultrasound probe is in the rectum. Now, normally if you're doing a transrectal biopsy, the needle is going to go through some sheath, and it's going to pass through an area above what we call the dentate line in the rectum. That doesn't have a lot of pain receptors, so you may not feel it as much when you're doing a transrectal. Whereas here, the skin, you feel needles in the skin. So most people will say that this is a little more painful. Now, this is the levator sheath, which is a muscle that sits right around. That's a landmark that we use. And you can see here that they've anesthetized the skin, hopefully well. And now the needle is going deeper to anesthetize the actual prostate. And the idea is to get underneath the levator and kind of create this little bleb of anesthesia just under here. Now, this is a great video. It's not my video. It's from the music collaboration, and I think they showed a great job. But if you take close attention to the video, you can see the pulse oximeter on the guy in his left hand, and this is obviously being done in an ambulatory OR, just like we do. And I think a lot of places, while you can do these in the clinic, I'm not saying that you can't, the pain tends to be an issue. A lot of people would prefer to be sedated. The sedation is not a general anesthetic. It's more like a colonoscopy. And for at least our group and of many others, it's more efficient to just do it that way. And I think it's just an easier experience, at least for most of our patients who prefer that over doing this in the clinic. Okay, so I think MRI and transperineal biopsy, I talked to you a little bit about the role of MRI and how we use it to target where we want to go. That's no different with transperineal. You're able to do a fusion biopsy, cognitive, however, you do your targeted biopsies with similar rates of detection to transrectal ultrasound. There is some thought that, because of transrectal ultrasound, the needle's passing from the bottom of the prostate, that it may be harder to hit the top of the prostate. If you're doing a transperineal, as I showed you, where the needle can come in, you can really see the top of the prostate better. So there's some thought that it's better for sampling anterior tumors, but again, we got to look at the data to see that. Again, some thought of better for sampling apical tumors. Now, I will say, as a person that's done a lot of both type of biopsies, when you're doing an anterior tumor transrectally, you got to push the needle through the prostate deeper because it's got to get to the front of the prostate, and so that does come with some discomfort to most men. They'll feel the pressure. And when you're doing an apical tumor, you really have to push on the prostate a little bit, and where the needle kind of comes out is like I said, lower than that dentate line, and so men may feel that more, and so the apical tumors do tend to be a little more painful, even on the transrectal, I think. But similar rates of detection, and I'll show you that. So, we talked a little bit about, I think someone mentioned Australia, being an area where you'd probably find a transperineal biopsy with no problem just walking down the street. And there's a lot of places in Europe where this is also the case. Norway, had a story of Roar Gulbrandsen, who's a 68-year-old who died from an infection. As I mentioned, these are serious infections. If you don't get into an ICU quickly, you can die because your blood pressure just bottoms out from the sepsis and the bacteria being in the blood. And his daughter, led a national campaign, educating people on transperineal biopsy, and they really eliminated biopsy-related deaths. The number of transperineal biopsies rose as transrectals went down, and you can see the number of deaths from biopsy went from just a little under 20 to almost zero, over that 5-year period of time. So really, just showing, impact by bringing that on. And then many of you who are in the field have probably heard about Trexit, which is some data from the UK really showing a lot of people making the move to increase, in the orange here, the number of transperineal biopsies doing at the same time decreasing the number of transrectal biopsies that we're doing. So we are seeing this trend kind of around the world of more of an uptake and an adoption of transperineal biopsy over transrectal. And I think the main reason, I believe firmly, is the antibiotic stewardship. It's a more painful biopsy. Everyone has shown that in their reports, but I think we go through that because of the fact that, it's just a better thing to do from an antibiotic stewardship standpoint. Now, obviously, what's most important is the cancer detection. So we'll just share some data with that. And I'm going to just, this is the part of the talk where it's probably the most data heavy. But I think it's the part that you're probably going to want to know the most in terms of, am I compromising myself to get at this newer type of biopsy that may not have as good cancer detection as this transrectal that people have been doing for 30 years? And I'll show you that that's not the case. But this graph is what we call a forest plot. And I'm just explaining it because we're going to see it in a few of the different slides I'll show. And usually, for the most part, when you're looking at a forest plot, it's kind of showing you a combination of, in this case, we're looking at a meta-analysis, and this is a bunch of different studies that they're looking at. And if the bar moves more to one side, it's usually favoring one approach. So here, if it's moving, if you see this dot basically favoring, this side, it meaning transrectal. On this side is transperineal. And you can see that, the dot is kind of right in the middle, showing that when you summarize all of these, you're not seeing a big difference between cancer detection with one approach versus the other. And I think these were all looking at cohort studies that they combined, observational studies that they combined in their meta-analysis, where they look at all the data, take all the patients, and then put the patients together as one large analysis, and they didn't see much difference. In this one, they just picked out the randomized trials. So there was about 6 of them. And, this is better quality data. So they're just kind of looking at these separately. And again, not much of a difference between each of the individual randomized trials, but even when you put them together, it was about the same. So no real big difference between cancer detection using one approach versus the other. Now, there were 3 randomized trials that have been done, I think, recently. And I'm just going to quickly highlight them. And they all are very similar in what they've shown. This was one done by Badr Mian, I think out of Maine. And this was one of the first one. It was a single center US study, and I think it was about 300 or so men in each arm. And again, here you're seeing this forest plot, so right down the middle means kind of like no difference between the two. The dot is kind of the point, where the actual data fell. Moving to the left means favoring transrectal. Moving to the right means favoring transperineal. And this, what we call this dashed line, is kind of what we call the confidence intervals, meaning that the truth really lies anywhere along this dashed line. And essentially, if this dashed line crosses the center point, it really means that they didn't see a difference. So you can see there's one study or one area here, this is a bunch of different groups of people. They're taking this trial and saying, okay, let's look at this group of people that had normal DRE, abnormal DRE, age above and below 70. So they're trying to stratify into all these different groups. And only in this group here, previous biopsy, yes, did they say that it favored transrectal in terms of better cancer detection. But for the most part, they found that there was no difference. And you can see here, they kind of just took some of the main groups here. In the overall population, 47% found in the transrectal, 43% cancer detection in the transperineal. When you look at the MRI positive group versus the MRI negative group, whether the tumor is anteriorly, whether the patient had a prior negative biopsy or not, for all of these different groups, they didn't see big differences between transrectal or transperineal in the detection of aggressive cancer. So suggesting it's similar between the two. This was a randomized trial called the PERFECT trial that was done in Europe. And here we're just looking at cancer detections, transperineal versus transrectal. There's just a little over 100 men in each group. And essentially, again, you're kind of seeing like a few different subgroups, so I'm just going to highlight, the areas where they saw a difference here. So overall, when they look at this, 48% of men they were able to detect cancer in the transperineal group. In the transrectal group, they found cancer in 54% of men. Now, that did sound like they found cancer better in the transrectal group. And while there was an improvement in the amount of cancer found, that improvement wasn't enough what they call statistical significance. So they say that 6.3% difference that they found could have been just due to a random error. It's not enough to say that was truly different. Now, the two areas where they felt that they did see a difference that could actually be real was with respect to posterior lesions. So lesions in the bottom part of the prostate, closer to the rectum. They found that transrectal did a better job of finding those. And they found that transperineal found more indolent cancer, the type that we don't want to find. Now, I don't understand why that was, because they were doing targeted biopsies, and you would assume that would depend on the MRI, not necessarily the approach. But it is what they found, and it was a randomized trial. But keep in mind, it wasn't a large number of men. Only a little over 100 in each arm here. But again, you could come out and say they didn't find the transperineal was any better in terms of cancer detection. And in fact, if you look at the data, there was no different, but there was a trend towards saying transrectal could have been actually better. And this is probably the best known one done by some of our guys, Edward Schaefer and Jim Hugh, who had a grant for this. This was the PREVENT trial that was recently published. And this is out of Journal of Urology. And you can see this table is just kind of highlighting some of the main takeaways here with respect to infection. So they didn't see any infection in the transperineal group. They found 4 guys in the transrectal group out of it's about 300 patients in each group. 4 guys, 1.4% had the infection in the transrectal group. Okay. With respect to any other major complications, urinary retention, they had 1 in the transperineal, 3 in the transrectal. So in the past, there had been a lot of concern that there was more urinary retention in the transperineal, but I think that was when we were doing those saturation biopsies, like I told you. Here, they did not see that was the case. Now, this is looking at pain, and for the most part, you can see the pain rating 3.6 versus 3. So it was a little bit more painful or perceived as painful in the transperineal versus transrectal. But again, not a big difference. So, when you look at the results, and we can just kind of take a look at them from the main point. There was no infections in the transperineal arm, 4 infections in the transrectal, and again, while that difference of, 1.4% existed there, it wasn't enough that they could reach what they call statistical significance, But again, I think we all do believe if there was more people, that would have been the case and it would have reached that. So we do think there's obviously less infections with transperineal, and I think that's the main rationale to do it. With respect to other, major side effects, bleeding, urinary retention, they didn't really see a big difference one way versus the other. With respect to at the bottom here, patient-related outcomes, again, transperineal was perceived to be a little more painful, but neither group reported a lot of pain. And then with cancer detection, that's the key thing here. They didn't really see a big difference. 53% detection using transperineal arm, 50% detection in the transrectal, not really seeing a difference between the two. So what do we do? I work at the Desai Sethi at the University of Miami. As Howard mentioned earlier, this is my partner, Bruno Nahar, and I. It was some time now ago, I want to say maybe definitely over 5 years, that we started our transperineal program. We use both the BK probe and the ExactView ultrasound. The ExactView, provides a very high definition view on ultrasound. So we do still do a lot of MRIs. We get MRIs ahead of time. But when we bring them to the actual OR for the biopsy, we use this ExactView micro ultrasound. And you can see the difference. On the left, this is conventional ultrasound, not the best image. And the the ExactView ultrasound has a much higher quality image. You can see the texture of the prostate a lot better here. This is not a typical fusion biopsy. Fusion biopsy, the way it is, a radiologist kind of draws, the area that's concerning on the MRI. And then when you do the biopsy, you're kind of overlapping the boundary of the MRI with the boundary of the ultrasound. And then you're hoping that those two are overlapped perfectly enough that when you target the little dot that the radiologist drew on the MRI, it's corresponding to the perfect place on the ultrasound. But, there's always room for error, and sometimes those things are not overlapped perfectly, and you may not even know when you're off because you don't have a strong enough ultrasound that you're seeing anything different in the area you're sampling. And that's where this makes a difference, is because of the high quality visualization. The idea is that you should be able to see it. So they really try to navigate you as more almost like a GPS to the area that the MRI suggested was concerning. And then the goal rather is not to just aim at what a radiologist draw, but rather to actually look using this tool, this ultrasound, to see if you see anything there or not. So I'm just going to show you another little video here. This is unlike, I'm going to stop this for a second. This is also not my video. This is actually from the company, and I think it was done somewhere in Europe. And unlike the other video where the guy was clearly asleep in the OR with the pulse oximeter, you can see in this case, he's actively participating in his biopsy as he's retracting his scrotum out of the way, which we don't have anyone do. Obviously, there's enough to worry about that day than to participate in assisting the doctor. But essentially, this is what they do, I guess. And you can see the imaging quality on the ultrasound is phenomenal. You can see right here, this centers, they think they show it out as a previous needle track, from previous biopsy that patient had. So you can see such high quality here in terms of, and as you magnify the field, you can see even better. So this is just showing a biopsy, you can see, unlike the previous needle kind of thing, the one thing I don't like about this is this grid, and they use a grid that you pass through. And so you're never passing the needle through a single point. And that's why I think we do these in the OR, is just because it's not a single needle, like a precision point, but they are making one for it. And then you get in, and ideally you would visualize what you're sampling. You can see this black area in the back here, which is where the tumor was that we were going after. So to finish off a little bit about where we are, obviously in any space now, people have to ask, what's going on in your AI portfolio for this space, and what are we doing in AI? And this is where a lot of my work in MRI right now comes in. If any of you have ever heard me talk in any active surveillance forums or anything like that, we've done a lot of work on this MRI algorithm that we built at the university called the habitat risk score. So this was developed by a partner of mine, Radka Stoyanova, who uses some of these functional sequences of the MRI that I told you about earlier. And she has a machine reading algorithm that essentially uses machine learning and various, features from each of these sequences to basically put up what she calls like a habitat risk score. So it looks at the MRI, and at a pixel by pixel level, it'll assess some of these, what we call radiomic features, and it'll assign a level of risk based on certain thresholds that we feed it. And we actually tested this out in radical prostatectomy specimens. And you can see here are the radical prostatectomy hormone specimens, and you can see that they've kind of drawn out the areas of the cancer. And you can see that the habitat risk score is actually showing you, these heat maps that are corresponding to the tumors in the histology. And what's actually a little bit better than what you typically see when you're doing just a regular MRI that the radiologist marks for you is you can see, for example, in this bottom left part, this orange is where the tumor is. But within this orange, you see this red, which tells us that that's the area of highest grade. Now, if you're looking at what a radiologist draw, they're just going to circle the whole thing. So you don't really know where to put your needle. Whereas here, And we know that, tumors can be very heterogeneous, and if you really want to sample the majority of the higher risk tumor, you want to try to get into that little red part, and you would have the ability to see that with this tool. Now that's not where we stop. Obviously there's a lot of gamers out there are doing probably a lot with augmented reality. And I think we're in the space now where we can see that come together. So this is in our OR. Let me just play this for you. This is kind of our micro exact view ultrasound showing up on the screen to the left. On the screen to the right is the actual MRI. And what you're going to see is you're getting a live feed from our Oculus kind of headset here. And you can see this is in the OR. So this is a live feed from the MRI that I'm moving over to this area. There's our anesthesiologist, thinking I'm crazy, just waving my hands in the air. This is the ultrasound that we're bringing up, and we're moving that over to the side here. And then we have everything kind of where we need. Now, I can't tell you that this is moving the needle much. This is not making a better detection. It's just something that's really cool at this point. But our goal is to now bring in the AI that I showed you earlier in terms of the habitat risk score and allow us to actually take a 3D model of it with the AI incorporated and then register that right onto the patient's prostate and the perineum so we can almost see right through them. And that's really, where we want to go with that. So this is just my family. They make coming home and doing everything worth it and a lot more fun than it would be without them. And I think that was pretty much everything that I had. Hopefully I didn't take too much time. And these are my contact information. There's my email, there's my Twitter handle if you guys want to take a picture or anything. And I'd be happy to, if you have any questions about anything, you can always email me and I will stop sharing and take questions.
Yes, Sanoj, thank you for an excellent presentation. Actually, you have spoken, but not to this group, but to a related group.
Oh, okay.
Not that it matters much, but we overlap. I'm the overlap. But I see a mention of something from Dr. Metzger, who's a retired urologist. And I received an email question from Keith G about this as well. Over the summer at the American Urological Association meeting, I think that was the one, Dr. Klotz presented a paper on microultrasound. Basically found, it was that whole inferior, non-inferior business that is confusing to me as a layman. But they basically found that microultrasound and MRI were a tie,
Yeah.
And so maybe you can expand on that. I don't know at Miami if you do microultrasound, and if you
We do.
don't,
No,
oh,
we do.
okay,
I mean, so the tool that I was showing you right there was the micro ultrasound, where you can see the not the augmented reality part, but the actual ultrasound where I was showing you can see the needle cores. That's the micro ultrasound. So you do have very good high definition pictures on an ultrasound that I think does basically it is equivalent, I think, to the quality you'll get in an MRI. Now, I'll say that with a caveat. So the trial you're talking about is the Optimum study, or
right,
Optimum study, and that was a study that they did where essentially they did an MRI. They would come in and do a targeted biopsy based on the MRI. They would do a random biopsy, and I actually think another person then came in without knowledge of the MRI and then did, a transrectal ultrasound, like sweeping the prostate on the ultrasound and then sampled anything that they saw. And what they found is, looking at the MRI and doing a targeted biopsy was the same as looking at the ultrasound and doing a targeted biopsy. Now, where I think the difference is, so one, you have to think about the patient flow. To do the ultrasound they're looking at, you would have to come in and have a transrectal ultrasound as a replacement almost from your MRI, right? And that's, I guess, what they're trying to say. Like, could you do the transrectal ultrasound, use that to decide whether you need a biopsy or not? So you'd actually come in, get the ultrasound. If you don't see anything, you don't do the biopsy. And Dr. Klotz actually does do some of that in his clinic. And I think maybe part of that would have been in Canada, it was harder to get an MRI, right? Most people that I know that use this do it as a way of facilitating the biopsy, like me. So I'll get the MRI still. I find, for me at least, my experience is better reading an MRI because there is a lot of user learning and a learning curve with using the micro ultrasound that you have to get good at learning what you're looking at. Like we've been using it for years, and I still sometimes wonder what I'm looking at. And I think that just comes with experience. And we're getting better and better at it. But I think for at least for me, and again, I may be biased, but it was easier to learn MRI. So I still use an MRI to kind of decide, is there something suspicious there? And then I use the micro ultrasound to help me get the needle into that area. But I don't use the micro ultrasound to replace the MRI, if that makes sense.
Yeah. Now, I'm going to ask one more question and then turn it over to Jeff. Although Jeff says you guys need to shake up that chat box and put some questions in. Otherwise, we'll punt. But you mentioned three studies in the past year looking at the MRIs. And but you didn't mention the fourth one, which was the British study from Oxford. And
Was it Stockholm? Is that with the biomarker incorporated, or?
no. Well, hold on one second. I can give it to you exact. And this, I don't mean this as a pop quiz or anything like that. I just want to mention it, the study. Let's see if I can find it here. Oh, fudge. It was, I think, it's called the Translate study.
Mm-hmm.
And it was presented at the European Association of Urology back in March. And they took the position that all these studies about infection were interesting, but were not necessarily the point. The point was these tests are being done to try to find prostate cancer. That's no pun intended. That's the bottom line. And they found the researchers at Oxford found a statistically significant thing that the Transperineal found 6% more cancers.
Mm-hmm.
And so, they said that was kind of a big deal. I don't know if you haven't run across that study, but
But was it a randomized study, or?
yes, it's the
Okay,
biggest
no, I haven't.
study, over 1,000. And I'm not here to school you.
Yeah.
I'm just saying, a big deal was made, at least in Europe, out of the study because it found 6% more cancers.
Mm-hmm.
So, I wonder if that shades your thinking at all.
No, it doesn't. I mean, if you have one study that was bigger that showed 6% more for transperineal, and you have three randomized trials that are really showing no difference, I think if you start to see more randomized trials that are definitely showing a trend that one is better. Now, I'm not saying that, this is evidence that we shouldn't be doing transperineal, no. But for the simple question of, is it better at detecting a cancer? You got a lot of factors that are going to go into there. Who was the radiologist? How were they good? Was that balanced properly through the arms? And it should be, right? But these are the factors that go into cancer detection: is the MRI, then the actual aiming of the biopsy, right? Because there's an actual fusion to the MRI targeted biopsy, how you do the template biopsy. So there's a lot of factors just outside did you do a transperineal, did you do a transrectal? And while in a good randomized trial that should all get balanced, you never know if in one setting, let's say, could it be then that the group that was doing the transrectals, just because they don't do as many anymore now, was not as experienced, and the group that's doing the transperineals had tons of experience. These are the factors I guess you have to look at, right? Especially when there's something as an outlier. If one trial is showing a benefit and the others weren't really looking at that. So it doesn't change it for me, but I think it just means we just need more data, I think. But to me, the cancer detection was never the main reason to do it.
Okay. Before I turn it over to Jeff, let me ask you, in your own practice, do you still do transrectal?
Yeah, we still have some.
So what's the ratio?
It's probably 80% transperineal, 20% transrectal. And to be honest, the transrectals that we have is just because we have it available in the clinic, and a lot of the guys do not like the pain of the transperineal in the clinic. But then they don't want to go through the ambulatory thing. And most of them are my active surveillance guys that have just been used to doing a transrectal biopsy and they don't want to change anything. And I think it's just more they didn't want to change and they hadn't had any problems.
Gotcha. Well, Jeff, do you want to dive in with a couple of questions?
Sure. Good morning, everybody from Northern California. Um, do you recommend, this is from Wayne Zimmerman, doctor, do you recommend a certain interval between biopsies? My urologist follows an 18-month interval. I am active surveillance.
Yeah, I mean, it depends on where you are in your surveillance. What are you surveying? MRI and things like that as well. So, if you just got diagnosed, I usually do a biopsy within, the first 12 to 18 months. After that, I try to spread it out to about 2 to 3 years and then 3 to 5 years. But it is a bit different if I'm following a person that only has a Gleason 6 versus if they have a Gleason 7. So there's a lot of factors that kind of go into it. I don't think there's one set protocol that I think works ideally for every guy. I think you kind of tailor it to the person and the cancer that's there.
Okay, thank you, doctor. A couple of other questions about urologists and using transperineal. One of them is, how many TP sessions is needed by a doctor to be too good at it, proficient. And then there's another question about how how to convince your urologist to switch to TP. Any ideas on that?
Um, yeah, I think to get good at it I think it depends again on what their experience is. If they've already been doing biopsies for a while, because you're still doing a transrectal ultrasound, right? So if you have experience doing a transrectal ultrasound and you know how to know where you're in the right side, left side, get to this part of the prostate, then I think the learning curve is not really that bad. The main thing is actually just the pain, and making sure you do a good local anesthetic so that they're not feeling pain. So most places, I think, when they start up, they'll start up in an ambulatory setting, where they can actually get some sedation and make sure that they're good at local anesthetic, and then that's good, and then slowly make that transition. And I would say in the first 20 to 50, you get to a point where you feel fairly comfortable. As far as transitioning your urologist over, I mean, I think just showing that the trend is moving in that direction, and patients are asking for this. And so I think patient advocacy is, the strongest thing.
Thank you, doctor. In terms of pain, we all go to the doctor or the dentist for one thing or another. When I go to the dentist, I tend to use over-the-counter stuff just to try to get through that fear of pain. Would you recommend, or is it desirable that men choose ibuprofen, acetaminophen, or aspirin? Would that help in terms of the reducing the pain factor?
Yeah,
Fear.
probably. I mean, I think again, it depends on the setting you're getting it done, right? So if you're going to a
Yeah.
place where they're going to sedate you, you shouldn't be having any pain during the procedure. And you want to be careful what you take doesn't interfere with anything that they're going to give you, right? So you want to make sure you've checked very carefully with the doctor and whoever is going to take care of your pain during that procedure. If you're doing it in a clinic setting where they're really not giving you anything on the local setting other than local anesthetic, then I think, yeah, that may help take the edge off a little bit. And then I think more than anything, it'll help kind of after the procedure, and I actually will tell people while we usually will tell them to hold their anti-inflammatories but prior to a procedure like that, just for blood thinning, I do find that sometimes an anti-inflammatory helps with the swelling and the discomfort a little bit better than, like I said, acetaminophen. But it really depends on what patients prefer, and I usually will just say take it in the post-op, but I don't necessarily recommend it beforehand.
Okay. Howard, back to you. You got anything?
Well, yeah, sure. And Jeff, let me clarify. You mentioned the dentist. I would not recommend going to the dentist for a transperineal biopsy. It's just too much of a reach, if you know what I
Yes.
mean.
Well, here in California, you never know.
Well, that's true. There would be really an alternative practitioner. But Dr.
Okay.
Punnen,
Okay.
yeah, Now, I found it interesting. I feel like you're emphasizing the stewardship aspect of antibiotics, and that's what drove the authorities in Europe, the European Association of Urologists, to give a preferential nod to transperineal. In the US, it shifted a little bit, saying that the two procedures are equal, but they do not seem to take much of an interest in stewardship in terms of their guidelines. They don't really mention that. I was an advisor,
Mhm.
Patient advisor on those guidelines, and I told them that AUA was taking the position of the neighbor who watches the house burn down and then calls the fire department. But that didn't, and I cited them all kinds of studies, but basically what they said was we needed more research. And so in the past year, there have been those four not double blind, but randomized studies. So, so there's a little bit of politics here, I think.
Yeah.
And
I think the other thing, Howard, that's also a part of that too, and you probably know this being on the guidelines, is, while the randomized studies were there in terms of like and these ones, had their primary endpoint about detection, and then they were powered more towards detection. There had been randomized studies done with the primary endpoint of infection that had shown, benefit, and had like the non-inferiority one, like I showed you, that suggested you don't need to give antibiotics because you're not seeing a difference whether you give it or not with the transperineal. But the problem with guidelines, and you see this, is when guidelines come out, especially if there's companies there or anything. In this case, there's not. They grab a guideline, and all of a sudden, it's a major thing that they can use to push the test and do this. And people have to respond to guidelines. Payers look at guidelines and decide whether they're going to do reimbursement. So if you put out there and say, hey, this is what we recommend transperineal for our guidelines, then there's a whole bunch of urologists that have no access, that not doing it. And not to say this is the right thing, but then now they're not doing guideline appropriate, care. And so that's why I think, they're very bullish on, they need that high level of data if they're going to come out and make that kind of statement, is what I think. And that happened early on, right? With MRI even. You'd see a lot of times where people would say MRI recommended, or, and not necessarily as if like this is what you have to do as a standard of care. And part of that was just there was access issues to it.
you mentioned the experience in Norway, and that was what gave the push towards transperineal in Europe and Australia. Now, the researcher who did that work, Dr. Johansson, it was his patient who died. He was a professor at the University of Oslo, and he reported, based on his research in Lancet, he reported that he estimated there were 2,000 deaths a year of American men from transrectal biopsies. I think there's about 2 million 2 million prostate biopsies overall. But when I mentioned that 2,000 death figure to American urologists, they usually raise an eyebrow. And I wonder if you're an eyebrow raiser or if you think that's plausible.
No, it's probably plausible. I mean, I don't think that we have a good sense of it, because sometimes like that men may not always come back. Like I know that there's times with patients of mine early on, especially, that would have had an infection afterwards, and I don't hear about it, until they're coming back to get the pathology results or something like that. So there's definitely a lot of times, where you may have a biopsy done in one health system and you're somewhere else when you got sick, and you get seen in a different
Right.
health system. So we probably underestimate the number.
Yeah, well, I think in his study, they followed it out for 30 days after the biopsy. Um, okay, Jeff, you want to take?
Yeah, we've got a few questions coming in. Here's one from gentleman Lauren asking, do you recommend a second opinion on the MRI before proceeding with targeted biopsy?
Yeah. So there's two, yeah. So for example, in the past, there was a lot of times where, so I look at my own MRIs. I think I told you guys that. And so if a patient comes to see me, I will look at the MRI. And if I see they came in with a PIRADS 4 or 5, and I see that it looks like a 4 or 5 to me, I don't always get it reviewed, by our radiologists. And if our radiologist called it and I look at it and I agree with that, then in my mind, I guess I'm providing the second opinion. What I do a lot now is if someone came in with a PIRADS 4 or 5 and I look at this and I say this is just BPH and I don't think it's that concerning. In the past, I would kind of just give them my thought and then they would kind of either go and get get another opinion or figure out whether they wanted the biopsy or not. Now I always do get that reviewed in-house with our people to make sure that they agreed with me. Um, so yeah, I do think it's worth it unless, you're going to a place where they know they do a really good job at reading MRI. If you're not sure, then it's worth getting a second opinion because it is a very variable test. But the thing you got to also think about is what's the game plan after that? What if you see a difference? What are you gonna, which one are you gonna choose? So I think your best bet is going to a place that does a high volume of these. When MRI became a thing, every place went and opened up an MRI shop, and you want to go to a place that does a high volume and has a radiologist that looks at a lot of these.
Okay, good. Thank you. There's been a lot of discussion lately about older men being maybe 75 or older and treatment. Do you care to comment on that?
Sorry, is that again with the older men? I missed the question. Can you
Oh
repeat
yeah,
it?
no, in terms of older men and needing, for example, a biopsy, which would some of us consider a little bit more dramatic than others, if you will. How often? For example, what about family health history or other tests, bloodborne tests, genetic tests, anything along that line?
Um, yeah, I mean, all of those things I think play a factor. You can get genetic tests, and if you're BRCA, then maybe your risk is obviously going to be higher than if you're not BRCA, but it's not going to tell you whether you have it or not, right?
Mhm.
And then there's a lot of biomarkers like the 4K score, like exosome, like some of the ones I've worked with again that are prognostic tests, but they're not telling you for sure whether you have it or not. And you're right, in older men, I think the threshold to do a biopsy is higher because they have competing risks, right? Even if you did find a prostate cancer in an older man, there's other factors, cardiac disease, other things that may be going on that person is more likely to die of than the cancer, right? So to me, I think MRI is been a nice tool in that way because let's say, you know, we still see a lot of 80-year-old men that get their first time PSA or have continued to get PSAs and it starts to go up. And you're really trying not to do harm in that type of person. And I think there's some benefit of being able to do an MRI. And ideally, if it's negative, I can almost feel very comfortable telling that person, look, if you got a negative MRI at 80, I really don't think we have to worry about anything, and I wouldn't bother with much of your PSA. And at least you can give some insurance that way. And even if you do see something like a PIRADS 4 or 5, you're talking with an organ confined situation, right? And again, this depends on your PSA. If it's 20, and the person's obviously the fittest 80-year-old sitting there with their father, that may be a different situation, right? But if it's gone from 4 to 5, and that's not something that and the person's like 85 coming in on oxygen, even if there's a PIRADS 4 or 5 there, I'm not so concerned about anything and said we're better off not bothering with the biopsy. So I think it's just given a nice non-invasive way of helping to decide what to do with these older men who have a lot of other risks. If they get sick, they're going to get much sicker from the biopsy,
Okay.
right?
Yeah, but we have another questioner, Charles, talking about a history of prostatitis, and he's wondering if that's a factor in the clinician's decisions.
Yeah, I mean it is because it gives you another reason for the PSA to be higher. So if someone has a history of prostatitis, you may not count that PSA as valuable, as meaningful, I guess, in your decision making. And prostatitis can impact the way an MRI looks as well. You'll see more of a diffuse darkness in the MRI as opposed to, a focal area. But if you have a radiologist that's not very good looking at that, they may call prostatitis a PIRADS 4 or 5, and then you bought yourself a biopsy.
Yeah.
Um,
Yeah.
Okay, Jeff,
Yes, sir.
let me step in here. Now, Doctor, you made a reference about a paragraph earlier, maybe two, about older men. But I think you were mainly talking about men who have not been diagnosed. What about
Yes. Yeah.
older men who have been diagnosed? When does surveillance end, or does
Yeah.
it end? Is it
Yeah.
just patient choice? What do the guidelines say?
Well, I mean, you know about autonomy as good as I do, Howard. I mean, it's always patient choice, right? I think in some ways the man on surveillance may be even safer than the man you don't know about, right? Because the man you don't know about has never been biopsied, so we can't say for sure what's going on or not going on in the prostate. Whereas the person on surveillance, you assume has had biopsies here and there, maybe, and we at least know that, they all that's been there is maybe a low grade or a little bit of intermediate. So again, the guidelines, uh, they'll talk about 75 to 80 as they give a range. I tend to see that guys tend to step away in the activeness of the surveillance, right? So, at some point around 75 to 80, people will say, well, I don't, let's just stop doing with the serial, biopsies, and we'll just do an MRI and a PSA and only do something if something changes. And then at that point, if it, and there's no magic number, you get to a point where you say, look, you're better off just with pure watchful waiting. And the likelihood of anything coming up is low. And they realize that, the likelihood of having some sort of false positive on an MRI and these things are not zero, right? And the other thing that goes on there is even if they did progress, to a 3+4 or a 4+3, are we even going to do anything now, right? So these are the conversations that we start to have. And really the answers that they have to that is what I use to kind of guide how intense the surveillance we're going to do or they want to do.
I gotcha.
Okay.
Now, um, okay, this comes from Keith G. Okay, we've been talking about transperineal biopsies, and you gave the history. Transperineal came first, then transrectal, but in modern times, is there more than one flavor, if I can use that word, for transperineal? You mentioned one technique or company that you use, but are there others
Oh,
doing
yeah.
transperineal?
Yeah, I mean, transperineal just basically means, I mean, for the most part, you are still doing, a transrectal ultrasound most places, and you're passing a needle through the perineum, and that's all that really means. But there's several, different vendors that offer it. I mean, I think most vendors in the biopsy space have realized if they're not doing it, then they're going to lose a lot of patients and providers. So they all have a transperineal platform. I know Peter Pinto, is actually working on trying to get rid of the actual transrectal ultrasound. Like, can you do kind of a very surface perineal ultrasound that you can see enough of the prostate to pass the needle and sample it adequately without having to put anything in the rectum?
Hmm.
Uh, so
Yeah,
I
we
don't know
should
where that, yeah,
say Dr. Pinto is at the National Cancer Institute.
yeah,
Not
yeah,
everybody may know him.
yeah.
Okay, another question. When doing an MRI targeted transperineal biopsy, how do you ensure that you're targeting the desired area of the prostate? Do you use a template?
So the template's not going to help you for a desired area of the prostate. I mean, the template is, we do a template because when I do a biopsy, we do MRI targeted biopsies and systematics. I am not at a point yet where I feel we should let go of the systematics. We still do see, and systematics for the most part, what I mean is doing the grid-like biopsies that come with an MRI targeted. So our approach typically is to do 2 biopsies to every area that the MRI showed. And then we do the grid-like sampling, and I usually do 6 on the left, 6 on the right. So that grid-like is just a grid-like. It doesn't go to a desired area. It's just to make sure we're not missing anything. Now, how we make sure we're getting to the desired area, we do this micro ultrasound view. So, we kind of, it's very much cognitive. And the difference there is, when you do a fusion, an ultrasound MRI fusion, you're depending on software to bring these two images that you outlined, one on the MRI, one on the ultrasound, and you're trying to bring the overlap together and getting software to kind of help with that. But it doesn't always register perfectly. And as a result of any mismatch, you could end up putting a needle into the wrong area. Now, cognitive biopsy is more, you're looking at the MRI, you're seeing something that's in the right base. So now you go on your ultrasound, you localize the right base, and you put your needle in that spot. Now, with the micro ultrasound that we use, the quality of the image is so good, and your ability to kind of enhance the area you're looking at and I guess magnify it is really good. So what we try to do is identify where in the MRI and the prostate the suspicious lesion is, go on the micro ultrasound to that area, and then we should be able to see, what it is we're looking for. And then for most real PIRADS 5s or 4s, and I say real because sometimes there's a radiologist that called a PIRADS 4 that I would have called negative, or a PIRADS 5 that I would have thought was a 3. But for ones that I really say, yeah, I agree with that, you can actually see something. It's not always the same. You can see, some sort of nodule, some sort of asymmetry, something that's different than the rest of the prostate in that area that tells you this is what you've been looking for. And you just get a needle right into that. Now, for a lot of the PIRADS 3s, I end up not seeing anything. And I think that's just telling of a PIRADS 3. So that's what we do.
Yeah, let me ask you this. We originally called this meeting till 1:30. Are you able to stay a little bit later to answer more questions? You can say no.
I'm not too much later because my kids are probably going to come home soon, and it's Saturday. But
Yeah.
but I don't mind.
Howard, I've got a few. You want me to jump in?
Yeah,
a good.
sure. Why don't you ask a few?
Sure, James Chandler. He indicates that he's a 3 plus 3. 4 years ago, 100 size of prostate, PSA at 9. Just had an MRI, PIRADS 4, transperineal 4 needles, no cancer found. Should I also get a transrectal?
Wait, so transperineal meaning 4 needles to the MRI target, or 4 needle biopsies of the whole biopsy was?
I don't know. I just have that written, but.
Yeah, I mean, sometimes people will just do a repeat biopsy where they just sample the lesion. Um, and depending on how concerning the lesion was, that may be okay. But usually when I do a repeat biopsy, the goal is to make sure we're not missing a worse cancer that we wouldn't want to watch. So I would have sampled anything that the MRI showed, and I would have done that grid-like sampling. And if on that we don't see a cancer, then that would have, I don't think you need to do a transrectal.
Yeah, he just mentioned to the target,
Yeah, and
adding
that's
to
what,
his question.
but I
Okay.
guess, I would have made sure there's a grid-like sampling with that. I mean, if you're gonna do a biopsy, in my view, you want to make sure it's as good a biopsy as you can.
Okay. And then another question from Norbert. Is a repeat decipher test recommended after a repeat biopsy, a genomic test?
We've done some analysis on this trial I told you about that we had, where we were getting deciphers on patients, and we did them on serial, and we didn't see that they changed that much, and the changes didn't track much to progression. So I haven't seen much value to that. Now, if your biopsy changes, like let's say for example you have more cores positive on this one, or a little bit of 3+4 came up and something's different now, then there may be some utility, because you may be talking about a different tumor, and seeing whether the biology changed would be helpful. So I think you got to look at that case by case.
And then we have another question is how can an MRI be used to monitor when the MRI images showed a high score, but biopsy, fusion guided 4 needles showed nothing? If the MRI was a false positive, how can the area be monitored? PSA is modest, etc.
Yeah. And again, this comes to the variability in MRI, so one of the things you could do is just have the MRI that they used for the biopsy and send that somewhere else to see if they would have also called it suspicious. Like I said, there's a lot that come in called 4 or 5 that I wouldn't have called that way. Now, if it does really look like a 5, let's say, that should have an 80% chance of detecting a bad cancer if it really is a 5. And so if they didn't see anything suspicious there, that's often when I repeat the MRI to see, did that get worse? Did it go away? Making sure it's not getting bigger to suggest that it was just missed.
Okay. And here again, another question is, what is the best way to find a transperineal provider near me?
So if you go on Precision Point, like Precision Point is they work with this company Euronav, which does a lot of well, I mean, Euronav is just the way of doing fusion biopsies, and they work with Philips, which is a BK ultrasound. But Precision Point essentially is as a tool that you put on the ultrasound that allows these little two needle guides, and they're a big facilitator of transperineal biopsies. And I feel like amongst providers, they've done a lot for patient provider awareness. So they have, I think, on their website a list of providers state by state. I've had a number of people come to us through Precision Point because they were looking for a provider. So that could be a good access person.
Okay, doctor, and then maybe perhaps finally, what should we expect in the future? We've got AI going on. I mean, all this technology flying at us. What's realistically in the pipeline?
Yeah, I mean, so I think, two things that I see coming soon, and we just need to, I think, get more data to show. One, so PSMA is an area that we see a lot of in terms of more staging of prostate cancer. In Australia, they've already done some trials looking at PSMA combined with MRI in active surveillance and for detection and deciding whether you need a biopsy. Now, the whole cost aspect of that, I think, needs to get looked at, because you're getting two scans for the price of one, and if it's not moving the needle that much. But I know Telix, for example, who is the gallium tracer vendor here, they're very interested in doing a similar study, and we've been working with it on that. So that's something we're going to eventually see happen. I think there's a lot of space for AI. MRI has definitely improved things a lot in the world of detection and diagnosis, but it's far from perfect. And I think AI will help us standardize it and probably improve it, so we can get more closer to saying, hey, your MRI is negative. You don't have to worry about something. We're not there yet, but I think AI could get us a lot closer to that.
Yes, sir. Thank you. Howard, back to you.
Yeah, we've talked here a lot about uh, MP MRI, multi-parametric. A study came out of at the AUA meeting. It was summarizing experience at the University of Michigan, where they have shifted typical guys like those here who are on surveillance with maybe a Gleason 6 or a 3+4. They've shifted these guys onto biparametric.
Mm-hmm.
And in case people don't know, biparametric cuts a step out and doesn't give the patient gadolinium. And I should be asking about gadolinium as well. But what is your take on biparametric? Is this a good way for people to go, especially to avoid gadolinium? And what is the controversy with gadolinium, and where does that stand now?
Yeah, so I mean, gadolinium is a contrast that they use in the MRIs to look for uptake of blood flow into areas of the prostate. It's less toxic to the kidney than iodine, so in that sense, I guess it may be a little bit better for people, that have any renal dysfunction. But when you look at the role of contrast in multiparametric MRI, I think as you're alluding to, Howard, it has been getting less and less, like in the way, we read an MRI, the most common thing is this PIRADS and rating scale that most radiologists use when they interpret MRI. And the contrast enhancement only actually helps in one area of PIRADS, and not a very robust area, to be honest. I mean, when I look at MRI, like I said, I look at all my own. I don't even look at the contrast enhanced ones. I just look at the T2 anatomical one and those restricted diffusion ones. And if we did do this, your time in the scanner would go down drastically. Access would go up drastically because you'd have more availability because less people are spending time in it. But there's a number of I mean, so there may be some radiologists that feel it's important. We worry about what we may be missing from cancer detection, a political aspect in terms of reimbursement if we're not, and hospitals make a lot of money from these MRIs. So I'm just putting all the things that are probably in the decision-making toolbox there. But if you're asking me, I think it's a very good move. for the country and for just the field.
Have you been making that shift in, well, I guess
No,
it's
we haven't.
okay, because at Michigan, for example, they say they've largely moved over to that, and they predicted they feel that's the future. It sounds like you do too.
I do too. I
Yeah,
think the Finns are radiologists that, that I don't think it would be hard to, but this is just the area you got to get consensus. And I think there's just more of a, if if PIRAD's guidelines committee, which is, what a lot of the will look at and say is our MRI up to, criteria, they still have that included, So people don't want to break away from the guidelines, I think, for the most part. But that's where it starts, if you ask me.
yeah. Well, you were talking about the monitoring in the context of the older guys.
Mm-hmm.
But I know you've done a lot of work with the 4K score. Personally, I've been followed with the PHI or PHI, Prostate Health Index, and that's preferred at certain institutions like at Northwestern and at I think Johns Hopkins. And I wonder, well, and at 4K score, they like that at Memorial Sloan Kettering because that's where it was developed. But I wonder in terms of following patients, if any of these make more sense than others. I mean, I've had my old doctor saying that it wasn't proven that the phi test was valuable for a patient on active surveillance. My own doctor says that's not true. So what gives?
Yeah, I mean, I think, the truth of it is that most of these tests have not been studied all that well in surveillance. There may be a few studies here and there done at a single institution. A lot of them are retrospective, so they're not a high level of evidence with them. We did one in our mass trial of 200 men using the 4K, and we didn't see that the 4K changed that much, but men that came in with a higher 4K were more likely to progress. So there is some evidence there, but I think Dan also looked at it, Dan Lin in the Canary cohort, and it did show some value for confirmatory biopsies. And I think that's probably where I think these markers have the strongest value right now is we use it in addition to an MRI to tell us could we be missing something, that the MRI may not have shown. And I think, that makes sense, at least in surveillance. For that first biopsy, we're kind of trying to make sure we use every tool possible to make sure we're not missing a higher grade cancer that we wouldn't want to watch, without knowing. But after that, for just straight up monitoring, we know PSA has very little value, but we still do it. I don't know that there's much data to say that most of these markers are any better.
Boy, we see that these guys have you on the hook for a few minutes, but they seem to want to get rid of you to go see your family. Jeff, do you have one last question?
I do not. I would let the good doctor go and enjoy his holiday weekend.
Okay. Well, do you enjoy car racing as much as you do bike racing?
I don't. I haven't been to the F1 or any of that stuff, but the bike racing I like. And thanks
Yeah.
for supporting
Thank you,
me.
doctor.
Yeah.
Thank you.
Well, so I ask everybody in this meeting to, Dr. Punnen sometimes asks for support to raise money for charity. So I want you all to help him out. So
Yeah.
but at any rate, I guess we'll call it quits for now. And really want to thank you for taking the time. Hope you do enjoy the weekend, but I hope you enjoy every day. What the
Yeah.
hell?
Well, it's been wonderful being with you guys. And Howard, I've known you for a while now, and really, just great that all you do in terms of patient advocacy and this group, I'm sure, as well. So thank you for giving me the time, and happy to come back anytime.
Thank you.
Thank you.
Excellent. Thank you.
Very
All
much.
Guys,
swell.
take
Thank you
care.
very much.